The ability to target specific markers on the surface of cancer cells has been something that we've strived for the last 30 years. And in myeloma, until now, a lot of attention has been expanded or expended targeting CD38. This has been a successful strategy, but what we want to do now is move on further and look at other targets on the myeloma cell surface. So BCMA is one of those markers. It's a very good marker for myeloma cells. And so a number of studies have been published looking at targeting BCMA. Most of those have focused on targeting T cells to the myeloma surface, so using bispecific antibodies and CAR T cells. Both of those kind of approaches are excellent. The other approach that's not being discussed quite so much is by putting a kind of toxin on an antibody and delivering that toxin directly to the myeloma plasma cell via BCMA. And so one of those molecules has recently been written up and published in The Lancet. And it's really interesting because in the first studies of this drug called belantamab mafodotin, the response rates looked really high at around 80% responses. But in the second analysis, in the recent study, the responses were much lower at around 30 to 40%, which makes you kind of consider, were the first results an anomaly or are the second results an anomaly? Well, the answer is neither were anomalous. It just highlights the issues of interpreting data in these early studies with few patients in them. And the answer is that it's a highly effective drug. When you do comparisons between drugs in that stage of disease, you have to be very careful, and we should wait to do those comparisons until there is more data and head-to-head comparisons work best. But for now, I think we can say that belantamab mafodotin is a highly effective drug that seems to work in relapsed refractory disease. There is a significant step forward for patients. The flip side of new drugs is you should always ask what their side effect profile is. And there seems to be some issue with sore eyes, blurred vision associated with the use of belantamab. And it seems that you get concentrations of the drug in the eyes, which cause this scleritis, where there's inflammation of the eye. And this leads to discontinuation of the dosing of belantamab in a significant proportion of patients. But I think it's a problem that can be addressed by changing the dosing schedule associated with this molecule, which I think will remove that side effect almost completely. So going forward, I think we have a highly active new drug that's going to change the outcome for many patients with myeloma.